Well, thank you. This being a vascular meeting, I wanted to bring a subject that related to vascular disease. I have no conflicts for this particular talk. So I wanted to talk about something that's newer that we're seeing more and more with an aging population, with a diabetic population increasing in this country, and that's the patient that has no options for revascularization. Because the one thing we cannot do as podiatrists or physicians in general is we can reconstruct these feet, we can do things such as this, but we can't cut out the actual cause, and that's one of the problems. And I just want to make a mention about everyday practice. You know, many podiatrists every day see many patients for, quote, routine care or what's called at-risk foot care. And these patients come in, for example, for onychomycosis management, and they qualify these patients for payment by Medicare by checking off a number of qualifying criteria. They have no pulses, they have decreased hair growth, decreased temperature, and we say that their circulation is so poor that it would be risky for these patients to even cut their own toenails. It needs to be done by a podiatrist. But the question is, what do you do about that vascular disease? And I know I've been seeing more and more lawsuits, at least in the Midwest, where podiatrists are being sued because a patient undergoes a natural history of vascular disease. Eventually they get gangrene or something happens, and you've got, you know, years and years and years of a podiatrist charging Medicare saying, well, this patient's got vascular disease, and yet no evaluation was ever performed, no referral was ever made, and the attorneys ask a straightforward question. It's like, well, doctor, if you knew this patient had vascular disease, very significant, why did you not refer them for an opinion from someone or evaluation? And I'm starting to see this more and more and more. So it's something for you to think about, because when we talk about vascular disease, particularly in the elderly patient who typically has atypical symptoms, and many of our elderly patients don't present with claudication, and they don't present with rest pain, and they have unusual presentations at times. So you want to screen for that more and more, because you want to remember, if you make a decision not to do something, that is a decision, and you could be held responsible for that, and forgetting the medical legal aspects, just being a good doctor. So when we look at amputation, these are typically the reasons why our patients come to amputation, as you all well know. And there's some new terminology floating about that. If you're not familiar with it, I thought I'd take a second just to familiarize you with it. Most of us have come to live with the term critical limb ischemia, whatever that means. The new in-term now is chronic limb-threatening ischemia. So right now, that's sort of the in-term. And now we talk about BAD and SAD and MAC, BAD being big artery disease, which, as has been pointed out previously, we have interventions for. Small artery disease, a much more difficult problem. Again, that's something we deal with as podiatrists every day. And then I want to say a word about this issue of medial arterial calcification, so-called Macaber's medial calcific sclerosis. And we have end-stage disease, unfortunately, and this is the so-called ischemic limb or the desert foot, where really this patient's down to no options at all. As far as this definition of chronic limb-threatening ischemia, this is in front of you, and these are patients that have this chronic ischemia. And as you know, the real issue is not so much amputation, it's the comorbids that they have, because very frequently we know these patients have corresponding coronary artery disease or renal vascular disease or carotid arterial disease. And many of these patients, their foot is actually a representation of a more generalized or more global vascular problem. Now, we throw around this term critical limb ischemia, and we hear this from our endovascular colleagues, from our vascular surgery colleagues, from our interventional radiology colleagues. But if you actually look at definitions, it's quite variable. And if we go through different definitions that are published as to what does critical limb ischemia mean, we see that there's no consistency in how we define that. We tend to define it as some type of panic point, an excuse for proceeding with various interventions, but everyone has their own definition of what is critical limb ischemia. And the fact is that critical limb ischemia does not mean amputation. And these are three really good studies that are available for anyone to review, where patients were diagnosed with critical limb ischemia And yet the majority of the patients did not end up with amputation. And almost always the critical factor, as John pointed out earlier, is not, for example, an ulceration. You could live with an ulcer your entire life. It's when that ulcer becomes infected or when that limb becomes gangrenous. That's when you cross from that stage 3 to stage 4. That's where the risk for amputation becomes greater. But when people lose their limb, almost always it's from the infection that they get. That's what causes us to proceed with the amputation, less commonly ischemic rest pain. It's not so much that they have, quote, critical limb ischemia. So we have these different classification systems. John has his own bias at University of Texas Health Science Center, San Antonio. I don't use that because it's too many words to spit out. I'm getting older now, John. I just can't remember these things. But, you know, when you communicate with your medical colleagues, for example, the Rutherford classification system has long been there. Easy to use, 0 meaning no vascular disease, mild, moderate, severe meaning mild, moderate, or severe claudication. Then we get into rest pain, and then local tissue loss and more a major tissue loss. So, and John made a good point to you that you should use classification systems of some type in your documentation. And so it doesn't look, as he said, like you're shooting from the hip. You want some reference point. As far as ulcers go, he mentioned the Wagner classification system, which is kind of a mishmash between anatomy and vascular disease. And I'm not exactly sure where it fits in, but I do know that I combine different classification systems, and sometimes I'll use Wagner if it's a stage 0, 1, 2, or 3, just to indicate depth. I always indicate the depth also. The Infectious Disease Society of America classification is very useful because you have patients that say, well, you know, you should have treated this more aggressively, doctor. There was error, that ulcer had redness around it. And we know that if you rely on something like the directions from the Infectious Disease Society of America, you don't have to hospitalize every patient that has an ulcer and some mild erythema. So you can make reference to published guidelines from our infectious disease consultants that say, no, I followed IDSA guidelines. So if you looked at an Alan Jacobs typical note, not that it makes it right or wrong, I will have perhaps Rutherford if it's more of a vascular case. I will always, if it's an ulcer, have at least Wagner and IDSA, plus I'll have actual measurements, plus I'll have a description. Because those of you in private practice and those of you who are student residents who are going to go into practice are going to learn very quickly that you can render the best care, but some of these patients turn on a dime. And all of a sudden, that benign appearing ulcer becomes a necrotic wound, and the patient becomes septic or severely infected, and it looks as though you've not been paying attention to that patient. John mentioned the Wi-Fi classification system. I personally like the Wi-Fi classification system. Actually, one of my former residents said it best. He said, you know, Dr. Jacobs, here's the Chris Sloan classification for wounds. When I walk in that room, he says, I look at that foot and I say, I could heal that. Or I say, ain't nothing I could do. I'm never going to heal this thing. And that's sort of his practical classification. What I like about Wi-Fi is it combines the things you actually think about when you first see a patient. You're looking at the complexity of that wound. You're looking at how infected it is or is not, and you're wondering about their vascular status. Now, obviously, there are other issues. How controlled their diabetes is, their comorbids, how much edema there is. Obviously, there's a variety of other things. But realistically, when you first assess a patient, these are the things that are foremost in your mind. And the Wi-Fi classification system, we don't have time to go into this, is very popular amongst our vascular and particularly our cardiology colleagues. So they communicate with each other using the Wi-Fi classification system. And you're looking at basically the Wagner classification system for wound depth. You're looking at the IDSA classification for the degree of infection, and you're looking at the degree of ischemia. And you could use this to sort of predict in a general sense how likely it is that the patient would benefit from some type of intervention and how likely the patient is to lose their leg to amputation. So I kind of like the Wi-Fi classification system, and if you have the time, go online and look at it. So more to the topic then, and that is the no option patient. What are we talking about? These are patients that have end-stage vascular disease, and vascular surgery says we have no target, and the interventional cardiologists say generally, I'm not sure we can have anything to offer this patient. So these are patients that you would typically talk to and their family or caretakers and say, I think amputation is likely going to be required here. But you have some patients that decline amputation, or the families refuse amputation, or you have situations where they say, is there not something else that you could do? And there are new procedures now that are available that can be used for this. My changer's not working for some reason, so maybe you can help me out there a little bit. So one of the procedures that is available now is arterialization of the deep veins. And how many of you have heard about this procedure or seen patients that have had this done? Just one. Okay. Can you help me out with the changer? It's just not. Oh, thank you. So our options are, number one, the no option patient to call on our ancient Egyptian colleagues and revivify the foot. That's probably not likely to happen. So these are our options, as you know, for patients that have this degree of severe ischemia. So our vascular surgeons say we can't help. Our interventionists say, well, we don't have any standard procedures that are available. You can debride the foot back to an area where you have a good bleeding, or amputate to a level of bleeding if it's available, and then some would argue hyperbaric oxygen. Medial calcification. We were taught when I was a student many, many years ago that this is nothing to worry about. It's a non-occlusive vascular process, arterial calcification, medial calcific sclerosis, don't worry about it. It'll artificially elevate your ankle pressures and may throw off some of your vascular studies, but it's nothing to worry about. And we know that that's simply not true. So when you see arterial calcification, keep in mind the following. Number one, as you know, it's more common in diabetic patients. We also see it in patients with end-stage renal disease, particularly patients that have secondary hyperparathyroid disease. It's also seen in autonomic neuropathy. Now, the other speakers, when they mention neuropathy, I think everyone keeps thinking about sensory neuropathy. Please don't forget that some of the major risk factors for ulceration include motor neuropathy, which nobody checks for, because many of these deformities that we see that increase pressures and shearing and cause these problems are the result of deformities of the foot because of motor neuropathy and inability of the skin to tolerate these pressures because of autonomic neuropathy. So I hope in the room, particularly the students and residents just getting started, expand your examination of these patients beyond just checking sensation. You got to do motor function and reflexes, and also check for manifestations of autonomic neuropathy, because autonomic neuropathy in particular is associated with edema, which is a risk factor for ulceration, is associated with cardiac disease, and it's silent myocardial disease and left ventricular dysfunction. We could go on and on and on. So when I see calcification, I don't dismiss this as unimportant. It's non-inclusive, and we do know that it is associated with increased risk of cardiovascular disease and increased risk of amputation and gangrene. So we no longer consider this benign. If you're not familiar with this, there is now a classification system available for foot x-rays that have calcification. So the dorsalis pedis is a score of 1, posterior tibial artery is a score of 2, the first intermetatarsal artery is a 3, the medial plantar artery of the great toe is 4, and then the digital arteries are 5, so that you can now classify the degree of calcification because it is a risk factor. Now, arterial disease can be big artery disease, it can be bad, it can be small artery disease, which is sad, and of course these portend a poor outcome. And there's also a classification system now for small artery disease, and it's arteriography based, so if you're not familiar with it, it's 1, 2, or 3, mild, moderate, or severe. And you can see here's 3 examples I've taken offline. This is not personal cases, as most of these things are going to be as I show you, but in the upper patient, you see good perfusion on the arteriogram. Then in the middle, you see moderate loss of perfusion, and on the bottom, you see very little perfusion. So you can classify small vessel disease. So this is the new procedure that's been around now for a couple of years. There's 2 proprietary versions of this, but in the United States, at least in St. Louis, most of this is being done in hybrid form. So these are patients that have small vessel disease. They're not candidates for a bypass. They're not candidates for a standard endovascular procedure. And the family says, is there something you could do to try to salvage this foot? And what you're going to do is fistulize an artery and a vein. You're going to take an artery and you're going to stent it to a vein, and you're going to essentially turn a vein into an artery. So this procedure that's getting more and more, in fact, it was discussed at this meeting here, I believe yesterday, with the vascular people, and this is called deep vein arterialization. So know that this is now an option for some of your patients. They typically do this through the femoral artery, and most commonly they're going to arterialize the lateral plantar vein. And you need to keep that in mind, because some of these patients you're going to be doing TMAs on, you're going to be doing major debridements, and you want to avoid damage to that lateral plantar vein, because that's now where the blood supply is coming from. So they'll go down, they will match up a level between the lateral plantar artery and the lateral plantar vein. They will then fistulize it with a wire. They'll dilate it. They'll stent from the vein, from the artery to the vein. They'll do a valvulotomy, and then they'll go ahead and deploy a stent so that the lateral plantar vein now becomes an artery. So basically, this is the procedure. And as I say, there are 2 companies that have proprietary systems for doing this. One of them that's the most popular in the rest of the world, I don't think is yet available in the United States, but we're getting this done more and more and more in St. Louis, and probably, I'm sure it's available here at Mount Sinai and institutions like that. So they're going to do this crossing for this. So this is what's being done, and you need to know something about it as a podiatrist. So number 1, if you have a necrotic wound and you say, I need to do a 4-foot amputation, I need to do a major debridement, and it's felt that without some form of revascularization, the patient's never going to heal, you don't do anything for at least 4 to 6 weeks unless you absolutely has to. You watch the patient's progress in the office. You can measure TCO2s, or what I do is watch the patient's progress. And if they look like they're slowly getting better, because it takes time for this to mature, so you don't make any major moves for at least 6 weeks. Remember, the patients are all going to be on dual antiplatelet therapy. So if you do debride them and play with them, you're going to be prepared for some significant hemorrhage and oozing. So make sure, I know the girls in my office, they run and they lay mats on the floor because they know I'm going to go in there and make a mess. And so they don't obviously like having to disinfect everything. The patients will swell like crazy after this procedure, so you can't be shocked or alarmed. And the other thing is, many of them have a lot of pain for the first 3 or 4 weeks after this procedure. So here again, if you're not familiar with deep vein arterialization, keep in mind again, they're going to swell, they're going to hurt like crazy, and you may want to provide them with appropriate analgesics and so forth. But try to postpone your TMA or your ray resection or even your digital amputation or any kind of major debridement for between 4 and 6 weeks when you get these patients. And when you do things, as I mentioned, be careful that you don't damage the lateral plantar vein, because you're going to ask anyway and find out what vein did you arterialize, but usually it's going to be the lateral plantar vein. And you want to monitor these patients for the obvious complications that you're going to see after any procedure like this. You don't close these wounds primarily early on, because the amount of swelling alone is going to disrupt your wound closure. So even though it's tempting to want to go ahead and do a debridement and close these things early on, the swelling is going to ruin everything. So be careful. Use your standard wound care. Negative pressure therapy is allowed. Skin grafts and skin graft substitutes are allowed. Hyperbaric oxygen, if you're an advocate of that, that's also allowed. Conservative debridements are allowed, again, watching yourself in the distribution of the lateral plantar vein. So that's a procedure I wanted to familiarize you with, because it's becoming increasingly popular with our percutaneous procedure performing colleagues. Now, what about palliative wound care? What about the patients that they say the patient is not a candidate for anything? Well, we go to meeting after meeting after meeting, and we're taught philosophically to heal wounds. But there's a subset of patients now, and you're going to see it more and more with an aging population and with a diabetic population, that we can't heal, and we're giving palliative care. So the question is not things we can do to a patient. The question is, are there things that we should do to a patient? And there are a lot of issues that arise. For example, I don't remember seeing terminal patients earlier in my career, and now I see more and more patients who are coming in with, terminal stage 4 cancers, or they're hospice patients and they have terrible wounds, or are being asked to evaluate these things. So as podiatrists, we're fully integrated in the healthcare system now, but we're seeing really challenging patients. And the question is healing even realistic in many of these patients? And what about the hospice patient? How aggressive do you get with someone who's accepted the fact that their death is inevitable and they have a terminal disease? I mean, should you be aggressively debriding these patients? Should you be doing, major surgical procedures on these patients? And, what you do for these patients has to be a decision between you and that patient and the caretaker or family member or whoever's identified as being responsible for the care of these patients. These are individual decisions, and everyone's going to go ahead and make their own decision. You have different suggestions as to what's important, but I want to make this point to you that when you're treating these patients palliative, where there's no option for treatment, it doesn't mean you don't do anything at all. You have to come to grips with the fact that what you're going to do probably is not going to hasten their healing or achieve healing at all. You want to try to relieve their pain. And I think that's something that we probably don't do enough. We all get scared off with this talk of the opioid crisis and everybody monitoring everything that you do, and everyone's fearful of someone's going to come and throw me in excessive analgesic writing jail, and we undertreat pain. And now, if you were on the other side of this, or if this were a family member of yours and they were suffering from ischemic pain, from wound pain, I think you'd probably want something done to at least relieve their pain. So give that some thought. Odor is frequently a problem, and you want to do things for that. You want to do as best you can to try to prevent an infection. Some of these large granular wounds or necrotic wounds, they ooze a lot. So you want to try to get the patient to enjoy as much as they can with what's left of their life. If they have greater than 2 years, you may refer them to a vascular colleague of life. You may see if they are in fact a candidate for at least palliative bypass surgery or palliative endovascular procedures if their life expectancy is less than 2 years. But again, these are decisions that have to be made between you. It requires a sit down between you and the patient and their family and caretakers, and say, we have a tough situation here. What do we want to do here? I'm perfectly willing to help you any way I can to make the remaining year or amount of time left, keep the patient comfortable, keep them without odor, so forth and so on. And again, we're seeing more and more of these patients that are headed to hospice or in hospice care, and this never used to be a part of our practices. You do want to make sure that they are getting adequate prevention for any kind of pressure ulcer. We used to call them the cubitus ulcers. Now they're pressure ulcers. Now, as far as pain goes, a couple suggestions I want to make to you. Usually these patients have multiple comorbids, and this could be problematic. You want to watch for delirium. Some of these patients, because of their pain or because of sepsis, do develop delirium. And those of you that do a lot of hospital-based work, like John does, and I certainly do, you do see patients that from that hospitalization can rather rapidly develop delirium, and pain can certainly do that. And you say, well, the patient's crazy. Well, they're not crazy. They're delirious because they're in constant pain. So here again, you got to discuss the reality of the situation with the family and say, we may be giving opioids on a regular basis. We're going to do everything we can to try to relieve that pain. So these are some of the alternatives that you have. You want to try to figure out what's causing the pain. Sometimes it's dressing changes that are a problem. So you might go with some warmer solutions when you change those dressings. You might order the facility or the hospital, if they're in-house, to give some analgesics prior to you making rounds with or without residents and changing those dressings. Keep the wounds a little bit moist. Don't let them dry out. That increases pain. One of the things I do a lot is local anesthetic blocks. And so I will frequently give a PT block or an anterior tibial nerve block at bedside. before a dressing change or in order to explore a wound at bedside. Another thing is topical analgesics. There's a lot of good compounded medications now, a lot of good topical analgesics that are available. You can consider a TENS unit in some of these patients. I write for a lot of gabapentin. I write for a lot of opioids. I use a lot of Playtal. Pentoxifylline, even though that's old time and you're told it doesn't work, there's some patients do very, very well with that. So there's lots of options that you have rather than being dismissive and just say, well, that's, the way it goes, and a lot of other options. As far as odor goes, this could be a real problem in some of these no-option patients where they just have a foul smell. It has its own consequences, and some of the things you could do, I'll frequently prescribe metronidazole, either orally, because that smell frequently is coming from anaerobic bacteria. If you're uncomfortable prescribing it orally, then have it crushed up and placed in the wound. You also have metronidazole gels, you have metronidazole creams, and you could compound metronidazole with other things, which I do a lot. So, for example, I could have the pharmacy compound up metronidazole with, for example, a topical antifungal or a topical antibiotic, or mix them all together and sort of get multiple effects at one time, get an antifungal effect, an antibacterial effect, get an anti-anaerobic effect. These are some other things that you could try. Oil of wintergreen around the wound sometimes helps. Crushing up charcoal briquettes and sprinkling that in the wound is sometimes helpful. I don't personally use coffee grounds, but I know people that do. Cat litter, again, is something that doesn't sound attractive, but it can help for these really foul, malodorous wounds. And, the patient's isolated socially. The family has difficulty with visits because of the wound. The patient themselves may have nausea and be sick from that smell. So there are some things you could do. Quickly about dry gangrene, I was again raised on dry gangrene, leave it alone. The toes will auto-amputate, but you do have to monitor these patients for potential infection. So sometimes if you mess with dry gangrene, you're sort of sorry you messed with it because you open up a problem that wouldn't have been there if you kind of left it alone. There's not that many studies on the fate of dry gangrene, but just so you see, here's one particular study saying that about half the patients did well, with allowing auto amputation, and none of these patients had any significant problems. This was a comparison looking at minor amputation and wound care for dry gangrene, trying to avoid major amputation, showing that yes, indeed, benign observation, making sure they're not getting an infection or a necrotizing infection, is adequate for dry gangrene. On the other hand, here's one that looked at a small, obviously not a very robust study, 12 patients with diabetes and dry gangrene, and only one patient out of the 12 studied had successful auto amputation. 8 of the 12 required some kind of amputation in the end, and they felt that waiting for auto amputation may result in worse outcomes. This was the most recent paper. It was in Journal of Foot and Ankle Surgery from Troy Buffelli's group up in wherever they are, Minnesota. And they looked at these dry gangrene patients and said that a number of them actually have underlying osteomyelitis. And so there is a concern in these patients for the potential spread of infection, and therefore suggested perhaps more aggressive treatment. So with dry gangrene, you have literature support both benign neglect and aggressive early treatment. If you're not going to amputate these patients, and I'm not suggesting that you do, but if you don't, you do want to monitor them for the onset of an infectious process. As far as debridement goes in patients that are end-stage disease and have no options for revascularization, the question you have to ask yourself is the patient going to benefit from you debriding these patients? It's like, I put this casket here, it's like the old joke they have about oncologists. And they say, why do they put nails in coffins? And the answer is to keep the oncologist from giving another dose of chemotherapy. And sometimes we want to debride these patients, and there's no hope they're going to benefit from that debridement. And oftentimes that debridement can cause them quite a bit of pain when ischemia is involved. So the issue you have to ask yourself is, does that patient actually require a debridement? And of course, as far as dressings go in these non-option patients, the question is, what type of dressing do you need? For what reason do you know? What are you trying trying to accomplish? And then unfortunately, a lot of times it also comes down to what will the insurances cover. So oftentimes we want to use a particular dressing and we can't get it covered. One thing for sure to avoid is wet to dry dressings. Wound cleaners are always helpful, in my opinion. As far as exudate controls, generally dressings which are foams or alginates or hydrofibers tend to be the best for trying to control that drainage, which is also helpful for controlling that odor. I mentioned that compounding is helpful if somebody will pay for it. Because I could look at a wound when I compound it and not ask, what product am I going to put on here? But I could say, what do I try to accomplish? So here again, I could use something for the anaerobe, something for the fungus, something for the bacterial infection. So in summary, in podiatry, we're now seeing more and more patients that are older. They have diseases with which peripheral arterial disease is associated, particularly diabetes. And we have to come to grips with some of these patients are not going to have vascular options. So in those cases, we need to look more at palliative care and palliative care principles. And I also wanted to familiarize you with this new procedure that is gaining tremendous popularity with our endovascular colleagues, and that's deep vein arterialization. So some patients I have had have done very well with deep vein arterialization, but you have to understand that this is going to take 6, maybe 8 weeks to mature, and these patients do look worse for a while, and you want to make sure you know what vein has been arterialized so you don't disrupt the functional artery, which was once the lateral plantar vein. So hopefully that'll provide a little bit of information for you, and I think they're scheduled for a break now, is that right? Yeah, okay, thank you.